Anyone here? All right. Sure. Good morning, everyone. Thank you for attending this morning. For the record, my name is Danny Smythe. I'm the Chief of Police here. One of the reasons we asked you to come here, I speak publicly a lot, and often one of the questions I get asked is, what keeps me awake at night? And, you know, we're always watching in the environment to see what's going on. But I have to say, in the last while, the emergence of the methamphetamine that we're experiencing in our community is getting to that level where it's starting to keep me awake at night. Certainly from a media perspective, there's probably not a week that goes by where we don't encounter some kind of sensational, newsworthy event that we may not even recognize at the time is associated to meth. And, you know, certainly I can go back to, you know, the walkway shooting that we had last year. We've had a couple of deaths that have occurred. There was a young man a couple of weeks ago that came off a balcony in the St. James area. There's been some robberies that we've reported on, and we're recognizing more and more that many of these events are associated to meth and to some of the people that are using meth. Certainly, the other impact that it's having in our community beyond what's being reported in the news is having a huge impact on our public service resources, whether that be the police, whether that be fire, paramedic, whether that be our hospitals. Certainly, it's having an impact there. One of the other things that I don't think I can understate is that often when we're encountering individuals that are kind of in that psychotic state of the meth-induced binge, if you will, is that it often puts our officers in a place where they are having to use force to control the situation. So it puts our officers in a use of force situation and puts them and frankly the public and the victims themselves, the drug users, at risk. Certainly, one of the things that we try to do when we combat this problem is to really educate and build public awareness around this. And that's really what we're asking your involvement here today. Today we've assembled a number of people here to bring, frankly, a lot of different perspective to this issue and how it's impacted in the community beyond just the police perspective. So Dr. Gerson is with us here today. He's going to speak from a medical perspective. Ryan Sneed from Fire and Paramedic is here today. He's going to talk a little bit about the impact that it's having on some of their frontline people. Mike Millard is here with us today, and he's going to bring a more personal aspect to how meth can impact someone's life. And of course, most of you have met Max. He's been our face in our organized crime division. A lot of what we do, Max's people are behind, including many of the public forums that we've been engaged in for well over a year now. We host regular public forums. Last year we emphasized a lot on fentanyl and meth and some of the things that we're doing. This is just really a continuation of that because of some of the upward trends that we're seeing with methamphetamine. So that's all I'm going to say on it for the moment. I'm going to kind of pass this along to each one of these people that we've assembled so that you can get a perspective of how this really is impacting us in the community. So, Max, you want to take it from there?
Good morning, everyone. Thank you, Chief, for your comments. For the record, my first name is Max, spelled M-A-X. My surname, Waddell, W-A, 2 D's, E-L-L, and I'm the Inspector of the Organized Crime Unit. As the Chief stated, really our purpose today is to advise not only the media, but the public about the significant increase in methamphetamine that we are seeing in the city of Winnipeg. I would say that 2016 really marked a significant increase in methamphetamine seizures. So for the year 2016, we had 490 seizures of meth that worked out to approximately 11,590 grams. In 2017, we had over 701 seizures at over 12,000 grams. That's about 211 more seizures from 16 to 17. And I guess what is most concerning to me is in the month of January for 2018, we've seized over 5,800 grams, which would equate to almost half the year's total for all of 17, which tells me that there's a trend before us. And that potential street value would equate to over $580,000, which obviously is very lucrative to the drug trade. You also will see a number of exhibits before you today. As all these matters are currently before the courts, obviously I am somewhat restricted as to all the details on these investigations, but I will try and answer those questions as best as possible. To your right, you can see some exhibits that would show you over 2.5 kilos of meth seized from a search warrant. Before you in the middle here would be over 1.5 kilos of meth with a street value of about $150,000. And over there, we just have a small amount of meth, but the purpose of pointing that out is that you can see that there's a firearm attached to this investigation, and that is very common for drug traffickers to protect their assets, if you will, and is very concerning for police in that respect. So the question you might want to ask is, why have we seen meth continue to rise in the city of Winnipeg? There's really 4 driving factors. First is the low cost of meth when compared to cocaine. At a 0.10 of a gram, which is just a very small amount of meth, you can purchase that on the street for about $10, compared to a 1/4 gram of cocaine is selling for about $20. 2 years ago, meth in the kilo version was selling at about $55,000. Today, you can buy a kilo of meth on the street for $17,000. So you can see how the price has continually lowered, making it again much more profitable for those who traffic illicit drugs. Secondarily, not only from the cost, the high you get from meth can last up towards 14 hours, where if you're taking a drug like crack cocaine, that really only lasts about 45 minutes. You can see the bang for buck with methamphetamine is also far superior over other illicit drugs. Sadly, I have to say that meth is very readily available in the city of Winnipeg. It's a drug that not only comes in internationally, but is also manufactured, not so much locally, but out west in British Columbia. It transfers across to Manitoba and is very accessible to those who wish to use it. And lastly, I would say the ease of production that goes with methamphetamine. It's a lot of off-the-counter or off-the-shelf products that you use, whether it be pseudoephedrine, which is a drug we know that's found in cold medication, ephedrine, other drugs like iodine, camp fuel, and other substances go into making meth. So really anyone can make this, and again makes it more readily available. While we haven't seen a large meth lab presence in Winnipeg, as history so states, in December of this year we were successful in uncovering what we believe is a large-scale meth lab in the 300 block of Kennedy Street. There we uncovered numerous exhibits of unknown liquids, powders, glassware, acetone, and butane. We had to call it our clandestine lab to deal with this matter because of the volatility that was involved. As the chief stated, there are many, many challenges that go along to law enforcement with methamphetamine. So as a police officer, when you come across someone who's acting irrationally, or in fact have a much unpredictable behavior, it's very difficult for us at that time to determine how to deal with that situation and what the underlying cause of that is. And potentially what that does, it puts us into a use of force encounter, and in extreme situations can be a lethal force encounter. Now when I say that, I want to be very clear that that's a last resort for police, but sometimes unfortunately we don't have to take, we would have to take such action. Meth is continuing to have a significant impact on frontline resources, and we know that the calls for service that we are responding to are attached to methamphetamine. It's very difficult for us to produce stats for you all today on that because we can't for sure say with 100% certainty that someone is on meth. I mean, anecdotally, and the way they're acting can tell us that, but unless we have, for instance, medical evidence to produce or to provide you that, it's difficult. But what I can tell you as far as criminal code charges go for both possession and trafficking, in 2015, we had 126 charges for possession of methamphetamine, and that rose to 327 in 2017. So that's over 201 charges in 1 year where people were charged being in possession. Similarly, for possess for the purpose of trafficking, Those charges rose from 90 in 2015 to over 262 by the end of 2017. So that's also 172 more charges. That gives you an indication of the work load that we have undertaken in the last 2 years. And you know, in speaking to our frontline officers, they also comment routinely that when they go to calls for service now, either the victim, the complainant, and or accused are somehow attached to this drug, methamphetamine. So what are police doing to combat this? You know, the chief highlighted it earlier. We're in the process of finalizing an illicit drug strategy that will encompass the actions of not only enforcement but also intervention and education. And I can tell you that probably the most important one is intervention in this strategy itself, in that we need to help people. And that's what we need, is the community needs to come together to help people that we know are in meth, get them the addictions, counseling, and assistance that they need so we can get them living in a more regular lifestyle. As the chief also stated, we have a public education forums, and in fact we have one at Gordon Bell High School this Monday, February the 12th at 7 o'clock at night, so I'd invite anyone to come out. Our drug experts will be on hand talking specifically about meth. We most certainly acknowledge that there's a lot more work to be done in this area, but I guess if I could leave you all with a statement is that we know that until we can reduce the demand of meth, the supply will continue to come into the city of Winnipeg. The community must work together and provide, as I said, education, addiction support, and counseling. And if at any time anyone ever has any information on the illicit drug subculture, you can call our drug tip line at 986-8435 or Crime Stoppers at 786-TIPS. I'm going to pass the event on to the other speakers right now, and I know you'll all have questions about the investigations. We'll save that to the end. So at this time, I'd like to call Dr. Grierson. Thank you.
Thank you, Max. Good morning, everybody. My name is Rob Grierson. Last name's Grierson. I'm the medical director for the Winnipeg Fire Paramedic Service and an emergency physician at Health Sciences Centre. So I'm going to kind of talk about the acute medical aspects of methamphetamine. And I think that the one message that needs to be said loud and clear, this is a very, very dangerous substance. It's dangerous to the users, it's almost lethal to the users in some instances, and it's also challenging for the healthcare system because it is so unpredictable. So in the acute phase, when someone's sort of high on meth, the effects can be wide-ranging. It can have physiologic effects where your heart rate can be elevated, your blood pressure elevated, your respiratory rate can be elevated, you can be agitated, unpredictable, you can have lapses in judgment, you can have superhuman powers, you can even have sudden cardiac death. Along with that, you can have psychological effects. So you can have increased energy, euphoria, very much impaired judgment, which leads to issues with, law and crime, and you have poor self-control. Then probably the most challenging aspect of methamphetamine, as you transition from the acute phase into sort of a more latent or prolonged phase, and these effects can be very prolonged. You can have psychotic symptoms. You can become psychotic, paranoid, you can be hallucinating, and these can last hours up to days. And the really challenging thing is, per individual, different uses of this drug can have different effects on an individual themselves, or if you have two individuals using the same substance, they can have completely different results. So from a healthcare standpoint, no two individuals and no two uses are exactly alike, which makes it very, very challenging to manage these patients both in the ambulance and field setting, which Chief Sneath's going to talk about, and certainly in the hospital setting. It's really unprecedented in terms of its unpredictability in the healthcare world. It's really interesting, regardless of dose, regardless of frequency of dose, regardless of route of administration or even the amount used, it is very, very unpredictable. And, as one might understand, in the illicit drug trade, there is no quality control. People don't know exactly what they're getting, and that leads to the unpredictability. So, I don't have a lot of comments. I'm going to be ready to take questions afterwards, but I think that the one message that needs to be said is this is a very, very dangerous substance, as are all illicit drugs. But the unpredictability of this is making it very challenging for our law enforcement providers because of the volatility of the people that they're dealing with. And then that makes it more challenging for the healthcare system because from one second to the next, individuals on methamphetamine can appear one way, and in a matter of seconds, that demeanor and that personality can completely change. And it can change in a number of ways where they might be, injurious or harmful to other people. They could be harmful to themselves. And that poses a real manpower and resource challenge. And frankly, from the medical end, there isn't one right answer to how to deal with this. I mean, it's been looked at around the world, and it's very challenging. You know, I'll use an analogy. If you're having a heart attack, the post-heart attack management can be pretty much guaranteed to be managed on a cardiology ward or on a coronary care unit. When you're high on meth and you're coming off of meth, all bets are off. We don't really know what you're going to look like from moment to moment or hour to hour, and what is the best resource to manage those patients. Sometimes you need to be in an acute care setting where you're on a cardiac monitor for 24 hours because there's a risk of cardiac death in the acute phase. Sometimes you might need to be in a locked psychiatric or mental health ward because of the acute paranoia and psychotic symptoms. And sometimes you need to be in between. And sometimes your need for those kind of care requirements can change moment to moment and second to second. And it's a real challenge to be able to deal with that in a timely fashion. And the other challenging thing is, even within a single individual who's using this drug, one reaction or one response can be different from one day to the next or the week to the next. And then just to kind of make it even more challenging, when people have tackled this use and this addiction, sometimes they can relapse into that psychotic and paranoid state without any warning. So this is a really, really dangerous substance. And I think prevention and getting the word out there about how dangerous this is probably the best way that we can challenge this. So thank you, and I'll be available for questions afterwards.
Hi, everyone. My name is Ryan Sneath. It's S-N-E-A-T-H. I'm the Assistant Chief of Paramedic Operations for the Fire Paramedic Service. So kind of to build on some of the points that Inspector Waddell said and Dr. Garrison said, it is a taxing on our resources in the Fire Paramedic Service on just how we manage these individuals because they become so complex. They often are experiencing true medical symptoms that would be in line with cardiac complaints, and they can legitimately having medical complaints, but those medical complaints become very complex for our crews to manage because of the psychosis and because of the other effects of the medication. Often these patients are agitated. Often these patients are extremely difficult to manage, which results in us having to use multiple resources at the scene. So not only would we have an ambulance there to treat their medical concern, but we end up having to have a fire apparatus there. We end up having to have a supervisor there, and we end up having to have the police at these instances to manage one individual's care. So on a issue for us as far as resource management for this group, it is very taxing for our organization. We've seen a significant increase from 2015 to 16 with our calls for overdoses. We've seen an even more significant increase into 2017, and that's our overall overdoses. So fentanyl has often been talked about by our organization and by the police as a significant issue, but this is an emerging issue that is not nearly as maybe immediately life-threatening, but it is causing a significant issue within our community as far as the longer-term effects that it has on these individuals and the longer-term effects that it has on our resource capacity in our organization. I'll also be available for any questions that you have related to the impact that it's had on our organization.
So I know we've painted a pretty dark picture here, and it is a serious issue for us as a community to deal with. But there's also hope here, and you know, our next guest here is Mike Millard, and I've known Mike for a few years now, and he's actually my neighbor. He was my neighbor, and I got to know him as a neighbor. But he also had a very personal journey that's associated with meth, and I'm going to let him tell his story. But I think the takeaway here is that there is hope for people, even no matter how dark and how low it gets. And Mike's a good example of that, and now how he's trying to give back to the community. So I'm hoping, as dark as the picture as we've painted, that you'll also see that there's some hope for people that are experiencing some of the negative sides of the meth world. So,
thank you, Danny. Hello, everybody. My name is Mike Millard, M-I-L-L-A-R-D. I'm 47 years old. I'm an addict. I'm in recovery. I've been in recovery for 2.5 years. But I understand every single day that it's a challenge and that there's things that I need to do to remain that way. I just wanted to share a little bit of my journey. Once I decided I wanted help, and I think people that want help have to make that decision on their own. Once I decided that I wanted help, it wasn't as easy as just going out and getting it. So my first interaction was with an emergency room, and no disrespect to anyone here associated with the emergency room system, but I was released very quickly. I was assessed, and I wasn't suicidal, and I think there's just such a volume of people looking for help that there wasn't a place for me. I went to the welfare system. I was a homeowner at the time. I wasn't paying my mortgage payments. I had no income, but I didn't sort of fit into that box of being someone that qualified for social assistance, so I couldn't get into a treatment center. I didn't have the money to pay. It wasn't until I had a couple of encounters with law enforcement and actually made it into the prison system, Headingley in the remand center, where I was able to start the detoxification process, which took about 3 or 4 weeks in my case, and then fortunately I was released on bail and into the Salvation Army. Treatment can't start when you have charges pending against you, so I had to stay in a shelter in the Boost Center for 4 months while I dealt with the charges I was facing before I could get into a detoxification center and then into the Anchorage program. And I was blessed to be able to go to Anchorage and stay there for 10 months. And when I completed the program there, I went on a waiting list for safe, sober housing. And a year later, I still hadn't found a suite. So it was someone that I had met in my journey, a counselor that had opened their home to me to give me that safe, supportive place. So a lot of great things have happened for me over the last 2.5 years. I've redeveloped a relationship with my son. I've developed a consulting business. I now work full time. And, you know, I can still remember what it was like to be stuck in addiction. And I give back through various programs, including Crystal Meth Anonymous, which is a new program, a voluntary program that started up in Winnipeg in the last few months. But even when I was in the problem, you have to deal with yourself before you can start giving back. Well, when I was in the problem, I wanted to help everyone around me and not focus on myself. So now that I'm out of the problem a little bit, I'm starting to find ways to give back, and I've been working with a number of community organizations, including the United Way, the Assiniboine Credit Union, Seed Winnipeg, to develop a residential gang exit program for men over the age of 24, and a related business that will employ the graduates from our program converting shipping containers to affordable housing. So our project name is About Face, and our social enterprise is called Sweet Home, and we're hoping to develop a 28-bed facility for up to 3 years of treatment and safe living for people that are looking to exit that part of the problem, the gang-related, crime-related part of the epidemic, which I would like to say is happening in this city. And the police can't arrest our way out of it. It takes everyone. It takes everyone can play their part. It's the people and places and things in addiction that addicts need to change. And the people part, we're all people in this room, and we all know people that struggle, or families that have people that struggle. And I think the biggest challenge is going from the old people to the new people, and there's often a gap between, and it's during that gap where you really need to rebuild your life. And I just hope that maybe if anybody could take anything away here today, that addiction, it's a terrible thing, but it happens to anyone. I grew up in a good family. I know people that have suffered from generations of trauma. We all ended up in the same place, and if we can all just do a little bit to make the world a better place, that would be great. So thank you for letting me share my story, and I appreciate your time and attention. Thank you.
Thank you, Mike. I really think that's tough to share a personal story like that so publicly. That's all we have in terms of prepared statement. I know there's some displays here. I'll open it up to questioning. Certainly, all of these people are experts in their own right, and they're available to respond to any questions that you might have.
Maybe Max, if we could ask you some questions first.
Go ahead.
You described kind of the prevalence of it. Like, I mean, where are people, where's police finding meth?
There's no boundaries. It doesn't matter if it's suburbia, in the core, all jurisdictions. It really, as Mike just alluded to, addictions can impact anyone, and it's really, we're finding it everywhere. So it's impacting our calls for service. It's impacting our officers. It's out there for sure.
It seems like you guys are, maybe I'm wrong in this, but it seems like you guys are pretty quick to now identify meth users. And you talked a little bit about your officers being out there, they can tell some of the differences. I guess as the WPS as a whole, do you think people are a little bit more aware of what this looks like and a lot, maybe having a little bit easier of a time identifying what is meth and what is coke, let's say?
If the truth be known, I would say that 2016, where we saw the real emergence of fentanyl and carfentanil in the city of Winnipeg, I think it honestly masked this methamphetamine user group that was slowly building momentum. Because as the doctors have indicated, fentanyl can be fatal almost immediately. Where methamphetamine, we see users over a longer period of time. We don't see that immediate impact or that immediate danger. So I think it's been quietly building momentum. I know it's like that in other jurisdictions, whether you go to Alberta, etc. They experience the same trend. So it was very much flatlined, and in 16, for whatever reason, it spiked. I can tell you right now, from our perspective with fentanyl right now, it is most certainly leveled off, thankfully. We still deal with it, but not to the significance that we did in late 2016 and early 2017.
I'm just going to branch you off of that. Just out of curiosity, how often do you find meth that's contaminated with fentanyl? Like, I know, I feel like it's been more cocaine than fentanyl because that looks similar and meth is used differently. So are there instances of that?
I would say that's very infrequent, and personally I'm not aware of that. It's more typical to cut cocaine with other drugs because of the cost, so they can take it further to make more profit, and that's the business of a drug dealer.
Now that pot's on its way to being legalized, a local organization has said that dealers are actually pushing meth on former pot users or people that they used to sell pot to. Is there any indication that that is what's happening?
I would say at this point in time that's really anecdotal information. I have no real proof to say that, although I believe the price of marijuana is going to continue to lower as time goes on, as it's the supply and demand factor that we're going to be looking at. So I have no proof to substantiate what you've said.
And, looking at, is this meth issue here, crisis, is it unique to Winnipeg, or is Edmonton and Calgary, Toronto, Vancouver, are they seeing the same issues?
So we're part of a group where Health Canada analyzes all the seizures that go across Canada. For the entire country of Canada, still cannabis is the highest amount of drug that is seized. Secondary to that is cocaine, and third to that is methamphetamine. In the province of Manitoba, methamphetamine is number one. Alberta right now would be cocaine with methamphetamine and secondary, and BC is really opioid based, as you get from all the reports out there. So in the third quarter of 17, which is the last data that I have, methamphetamine was the leader in seizures for the province of Manitoba.
What do you attribute that to?
Well, as I said, all the factors. It's the low cost. It's the ease of production.
Does it have anything to do with our geography, where Winnipeg is located, in terms of where these drugs are coming from? You said BC, but...
Yeah, I mean, we're in the center of Canada, most certainly. I mean, we don't limit it to just coming from Canada. We know that the Mexican drug cartels ship this stuff up to Chicago and then it gets across borders. I've said that many times before. So it's not really limited to being in the center of Canada. BC has an extreme opioid crisis because I think the weather is conducive to that. People can be outside, users, etc. The meth users we're finding are not necessarily just outside because their weather is not conducive to people being outside, right? It's cold. People need to go inside. So it really matters where you're residing as to, I think, what drugs are being sold.
How hard is it? I know with fentanyl, it's maybe easy to get the message out that fentanyl is a massive issue because there's drugs being laced, and the average person out there that could have hit home. How hard is it to kind of get the meth message out there? Because a lot of moms sitting at home right now are saying, well, my kids aren't going to smoke meth. So how hard is it for you guys to really push out that it is a massive issue?
It's a difficult challenge, and that's why we're before you today. We're going to ask all the media to help spread that message. That's why we hold public forums. That's why we work closely with our partners in the WRHA. We all have to collectively work together if we're going to combat this problem.
I know you said before that a lot of it is coming in, but as you're seeing more and more the prevalence of people using it, do you expect to find and dismantle more of these drug labs in Winnipeg and see more of it produced here?
I fully expect that who I would refer to as independent drug dealers are going to get more involved in this. Right now the split's about 80-20. We know 20% of what's coming in here is domestic, 80% is still coming international. But the profitability that goes with this, that's what drives drug dealers every single day. I fully expect we will see more meth labs in the future.
In terms of these 3 search warrants that were executed, is there any indication that there was a connection between these, or are they 3 distinct separate things?
They are 3 distinct separate investigations.
How long were the investigations ongoing for prior to executing these search warrants? Is that something you can speak to?
Yeah, honestly, I don't have exact timelines for you.
And I want to make sure I got something down right that you said in your initial remarks. Seizures in January 2018,
yes.
In terms of the total amount, that would be half of seizures seen in 2017?
That's right. So we were just over 12,000 for the entire year of 2017, and in the month of January we had 5,800 grams seized.
And
that equates to a street value of $580,000.
I mean, that's pretty shocking. Can you perhaps just speak to, I mean, how concerning that is from a law enforcement standpoint to see a spike like that, so significantly?
It's a short time frame, so statistically speaking, we have to be careful with that, right? I don't know what's going to come in February, but as an investigator, absolutely, when we come across this amount of methamphetamine in just 1 month, is that an indicator for the rest of the year? And if it was, absolutely, police would be very concerned, as should all of you.
Is there a certain gang that this is affiliated with? Is there one particular main player in this?
I can't comment on that at this time.
In terms of the specific seizures that you're talking about today, are you able to elaborate a little bit in terms of search warrants in various areas of Winnipeg? Or are you able to tell us where? Go into specifics there?
Yeah, no, you know what, I'm sorry. Right at this point in time, these investigations themselves, they have been concluded, but as always, police are ongoing in trying to disrupt the flow of drugs into the city of Winnipeg. So I just, at this point in time, we're not going to release any further details relative to locations, individuals involved. We purposely did that.
Are these seizures connected in any way?
No, they're not. 3 separate incidents, 3 separate seizures.
In terms of this strategy that you mentioned that you're currently putting together, is there any sort of timeline on when that will be finalized, when you expect to roll this out?
It will be the spring of this year, middle of April to be pretty much exact.
Okay. And
is it a public education strategy, or is it a strategy internally within the force in terms of how you respond to these calls or crack down on this?
It's a combination of enforcement, intervention, and education. All 3 will be the mainstay that will guide us to hopefully assist those in need.
Are you looking to any other forces that have dealt with this?
We work collectively with other agencies, yes.
So you talk about hope, to kind of maybe curbing this. Is that kind of, because the fentanyl use, you know, you talked and you said it's kind of leveled off.
Yes.
Is that the hope for this as well? Because it doesn't seem like this is something that just, it's not going to be eradicated. Is it hope that it will just level off after time?
I attribute the reduction in fentanyl use with the education campaigns that not only the police service has done, the province of Manitoba has done, the Winnipeg Regional Health Authority has done. I think we, in effect, put the mindset in people knowing that if you take fentanyl, you could potentially die. It is extremely dangerous. And my hope is with methamphetamine, as the doctor has indicated as well, it is extremely toxic and you could potentially die. It just doesn't happen quite as quickly. It is very toxic. It makes you become very unpredictable, irrational, etc. So that is our hope.
You mentioned that officers are seeing meth more and more connected to just going out on calls, and someone associated with what they're responding to is connected to meth. And perhaps there aren't really like stats on this, but anecdotally, like how often are officers coming across scenes or incidents where meth is there? Like how many resources is this tying up?
Well, it depends on the specific incident. If we come across an individual who is high on what we believe is meth, now those officers have to transport this individual to the hospital, and they have to sit with them, not only for the safety of that individual, but for the staff in the hospital because of the unpredictability of it. So it's, you know, can I say it's daily? I don't have that staff, but I can tell you it's significantly impacting it. And anecdotally, they're saying they see it at almost all the calls they go to. It's out there.
So then have we seen a rise at all in crime just specifically because of meth? Maybe not with dealing or anything, but property crime and things of that nature.
We're working to try and make that linkage, but again, how do I prove that someone is in fact actually on meth? Without taking blood, how would we know? They're acting irrational, but I can't prove that. So we're doing our best to bring those statistics together.
Is there any, with meth, or with fentanyl, sorry, there's obviously a grave danger to even anybody who comes in contact with it. Is that the case at all with meth? You know, when officers are maybe handling it, or if they come in contact with it just through their...
No, we take precautions. We're always wearing gloves or masks or whatever the case, but no, you know, a regular individual, if you came upon meth, and unless you're ingesting it, there's no real danger as opposed to fentanyl where you could accidentally inhale some dust or powder. That's where the danger is with that fentanyl.
So can you talk about the demographic of people that are using meth? I know when you and I spoke in the fall, you were saying that this is crossing all demographics. Are you seeing it in younger and younger people?
No, we're not. It's late teens, in your 20s, into your 30s, and really no boundaries. But we're not seeing a huge user group in our youth, and that's our hope, is to keep it that way.
Sorry, I was just going to say, I don't know if one of the other two gentlemen can answer this question, but are we seeing any injuries, any serious injuries with regards to paramedics, medics, or hospital staff that have to deal with these people that are high in meth that come into the hospital that are in events?
So I can't speak to the hospital staff. I don't have any of that information. I haven't seen any injuries related to our staff, but there is, I'll say, as a result of significant precautions that we've taken related to this. So we have agitated patient protocols in place that involve the police, that involve the other apparatus that I mentioned previously. So I think it's just in order to manage these patients effectively and in a safe manner for both them and for our staff, it just requires that many more resources for us, which is why it's so problematic.
Have people had to be restrained at all?
Absolutely, yeah.
Can you talk a little bit about what happens? Say you get a call, and this isn't related to a crime where someone has maybe committed a crime, but you get a call that someone's clearly in some type of drug psychosis.
Yep.
Kind of how, whether you tag team that with police and kind of explain to me, walk me through how that would be dealt with.
Sure. So our crews, always their first priority is scene safety. So if the scene is not safe for them to enter, they will not enter until police have arrived to say that the scene is safe for them to enter. So I'll just stop there for a second and say that can result in a delay in care for somebody. If the scene is not safe for our crews to enter, they're not going to enter into a dangerous situation. And so they will be contacting the police immediately. So if the crew arrives, we may not know what has caused the psychotic behavior or the abnormal behavior, but the crews will be calling for police resources right away. They'll be calling for a supervisor to come. They'll be calling for additional resources from our department to come. They'll be assessing the individual as best as they can, but we do have chemical sedation, we do have physical restraint that we do on these individuals in order to assess them and treat them properly.
Are you seeing more suspected meth use? Anecdotally, police would feel like they're coming across it more frequently. Is that the case?
Yeah.
Yeah.
Just wondering if the doctor could kind of take us through, what kind of give us a description or kind of give us an idea. Like, I know we've heard what it's kind of the generic symptoms of someone that's on meth, but can you kind of give us an idea, an example of what it's really like?
I mean, from my standpoint, observing patients, again, it's a broad spectrum. And I mean, so if you take someone who, as Chief Sneath talked about, if they're agitated, I mean, literally they're like almost like a caged animal in some instances. So they can be revved right up, their heart rate will be up, they'll be flushed, they'll be sweaty, they'll be paranoid, right? So when people come in, whether it's police, fire, ambulance, they won't be seeing those people as there to help. They'll be seeing those people as potentially there to hurt them or harm them. And so that's why they react, and that's why in some instances it requires so many people, not only for the safety of the people providing care, but for the safety of that individual. So that's one end of the spectrum where they can be horribly accelerated and agitated. Sometimes the patients can come in and they're very cooperative, and they may be having cardiac symptoms, for instance. I mean, it's well known that when you take an amphetamine type of medication, it's the way it works in the body is it accelerates everything. So it increases your blood pressure, it increases your heart rate, it increases your respiratory rate. And I mean, if it's somebody with some underlying heart disease, that's going to cause problems with the heart. So they could come in and they could be managed very much like a normal patient who's not on medications or drugs with heart problems. And then during the course of that evaluation, that latent phase where they can become psychotic and paranoid and hallucinate can transition into that. And again, the real challenge is you can be managing the patient cooperatively and like a cardiac patient, and all of a sudden in a matter of minutes their whole demeanor can change. And so that's the real struggle. And I mean, if we compare this to fentanyl, I mean, fentanyl is a deadly medication or substance. I mean, I look at it as a medication because we've used fentanyl for years, and in the proper setting in the hospital, it's a very good painkiller analgesic. When it's used illicitly and dangerously, it's obviously dangerous. But fentanyl, as deadly as it is very predictable in terms of its course and the management from it. So, you know, whether it's a field provider providing care to someone with a fentanyl or an opiate overdose, or whether it's us in the hospital, the course and the treatment is pretty consistent in those patients. The real challenge in this is there is no consistent course. You can't, you know, if you have an individual who comes into the hospital who has been in there previously having used methamphetamine, you can't look back in their chart and say, well, you know, 2 months ago, this is how they behaved, and base anything on that previous presentation. Because this presentation could be completely different. It could go down a completely different road, and now you're dealing with a completely different type of a challenge. And I can't underestimate how challenging that is to manage a patient when you really can't predict the course that they're going to take. And this is not unique to Winnipeg, this is unique to methamphetamine around the world, right? Whether you look at literature from the United States, literature from Australia, they're all saying the same thing.
Would you say it's highly addictive?
That's a good question. If interestingly enough, worldwide, if you look at the statistics, about 1/3 of users of crystal methamphetamine or methamphetamine are frequent users, which would mean they use it probably weekly or even daily. 2/3 are periodic users. So from that standpoint, I don't know what the numbers are for other types of illicit drugs, but that sort of gives you an idea. The really challenging part is those infrequent users. You know, one dose can be enough to set off this entire cascade of you know, events, and that's where it becomes so unpredictable.
Would Mike be able to ask?
Yeah, of course. Sure.
I mean, we've asked the doctor about kind of it, but from your perspective, having used what are the physiological, psychological, what happens when you're on it?
My course of addiction went over about 20 years. So it started off with alcohol, marijuana, recreational use of cocaine. That was about the first 18 years of my journey. Basically what I can tell you about crystal meth, from the first or second time I tried it, I never stopped. I never made a mortgage payment again. I never paid for my driver's license, hydro, water. It just became, I just became fixated on it. There's a tug-of-war that goes on between the healthy people and family in your life and the subculture of meth users, and you get pulled from your old world into a new world. And in my case, it took losing everything, including my freedom, to get on a new course. In my experience as an addict, I don't think I've seen a drug marketed in such a predatory way as crystal meth. I think what happens if you're a man, they look at you, what you have, what they can take from you, how long it's going to take, and then once everything's gone, I think they'd like to put you to work. If you're a female, we all know the stories that happen there. They're terrible. Human exploitation, all kinds of things. So I think that's what really, the difference that I see with this drug compared to other drugs that I've struggled with in my life. The other thing that I wanted to mention that I didn't mention before is really the addiction part of it is a secondary component. A lot of the people that are struggling with addiction are actually struggling with themselves. They've had to deal with complex trauma throughout their life, or unresolved issues, and it's my experience in addiction that the addiction is really a byproduct of a much deeper problem. And I think the call for action here today, and the different pieces having to come together, whether it's on the enforcement, the intervention, the education, or the rehabilitation in the case of what we're trying to do. You know, everybody needs to be working together to make all those pieces. It's the synergy that's going to come from that.
I'm sorry, and just one other thing. I just wrote wrong word. Every experience different on the drug, like when you're on it, or did it become just How was the high always the same?
My experience with it is really what I observed was more scary than my own behavior. So I didn't go into deep psychotic episodes, but I certainly witnessed them. They're very scary. Like axes, knives, rocks, you name it. Things I don't even really like to remember. All I can tell you is it's like a ticking time bomb, and it usually happens, in my experience, around the second or third day of continuous use. Some people go 5, 6, 7 days. I've met people in treatment that never come out of that psychotic state. They get there and they stay there, and I'm just fortunate that my experience with this drug was short enough that it didn't have a long-term mental health implication for me, but they certainly exist.
How often would you take it?
I'd either be awake or I'd be asleep. If I was awake, I was using it, usually 2 or 3 days in a row, and go to bed for a couple of days. During that 1 year period, nothing else really mattered.
First off, congrats on your sobriety, by the way.
Thank you very much.
In doing past stories, I've heard people describe their first time using a substance as kind of like an instant kinship. I know some people have said that I took it and I just knew this was what I was going to do for the rest of my life. Was that your experience, like the first time you?
To be honest with you, for me, the value proposition for crystal meth was it was less expensive than cocaine. And it opened kind of a new world of people that I didn't need but wanted. And I went chasing after sort of people and places and things. And I think before I knew it, it just took a hold of me. What I can tell is it doesn't take long for it to start affecting your morality, your conscience, your sense of joy, your ability to feel. Even, the first year and a half into my recovery, I had a hard time celebrating anything. I just was kind of emotionally dull. And I'm starting to get that back. I'm starting to feel some of that joy. And I think that's where the challenge is for a lot of people in recovery. It's in that in-between state where you're used to being picked up by the drug that's now been removed. Your body can't, and I'm not a doctor, can't produce that naturally, so you're just in a lull. And it's easy to get bored, it's easy to go back, and it's during that time, that year and a half, where it's really critical that people can reach out and get those new people in new places and new tools that they can use to keep themselves sober and be productive members of the community.
In terms of the dangers it just poses to someone from a health perspective, that's quite clear. But can you perhaps speak to the dangers it poses to the situations it places you in? You spoke about kind of the darkness of the subculture, the meth subculture in the city.
Yeah. Everybody, in my experience, everybody that uses meth pays for it in some way. So some people steal bikes, other people shoplift from stores, break into cars, steal from their employers, sell drugs. The list goes on and on. These guys would be able to tell you a lot better than I can the types of crimes that are associated. But the reality is, I think that anyone that's using needs to pay for it somehow. And in some of those crimes that they commit and in the state that they are in, there is definitely a propensity for violence. I think you've already also heard comments about the value of this drug and the desire to protect it. And it wasn't uncommon in that world to see people that were armed. Or saying that they were armed, and then you see all kinds of things that I don't really want to repeat, but everybody should be concerned.
Okay.
Thank you.
Go ahead.
That kind of concludes, I guess. Again, I see the media playing a big role in this as well, and just helping to further the message and educate. So I thank you for your interest here today, and hopefully we can tackle this more effectively together as a community.
Okay, so if we're going to do this, we're going to do one table at a time. Okay, I don't want other people focused only one thing at a time, so you can start with this one over here, please.
Max, can I just
Yeah, so let's do this and then 100%. Okay. So this represents 2.5 tables.
Max, just wait. Max, you're going to get set up.
The three tables, are these the three separate buses?
They're all separate and they're intentionally left separate for continuity purposes. We need to do this. So you have a variety of different drugs here. You have